This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's a case report detailing therapies of last resort in a pediatric patient suffering from super-refractory status epilepticus, or SRSE.
This is a heavy topic, Alara. For our residents and students listening, status epilepticus is always a red phone situation, but SRSE represents the absolute limit of our pharmacological interventions. Before we dive into the specific case, let's ground everyone in the definitions used in this paper. How exactly are the authors defining the progression from refractory to super-refractory?
Right. The paper defines refractory status epilepticus, or RSE, and super-refractory status epilepticus, SRSE, by the persistence of seizure activity beyond 24 hours despite the initiation of anesthetic treatment. It's essentially a failure of the mechanisms responsible for seizure termination.
And the stats in this paper are quite sobering.
They really are. The annual incidence of SRSE is estimated at 1.2 to 3 per 100,000 individuals. But here is the kicker for those in the ICU. While many patients start as RSE, about 11 to 43% of those cases evolve into SRSE. In the pediatric population, we're looking at a mortality rate of 30 to 50%, which can climb to 60% if the seizure duration is prolonged.
It's a literal race against time to prevent what the authors describe as a cascade of cerebral damage, neuronal necrosis, gliosis, and network reorganization. Which brings us to this specific case. It involves an 8-year-old girl with a very complex baseline.
Exactly. She was an 8-year-old Caucasian girl with significant pre-existing challenges: spastic quadriplegic cerebral palsy, drug-resistant epilepsy, or DRE, cortical visual impairment, and bilateral hearing loss. She was PEG-fed due to dysphagia. Her baseline anti-seizure regimen was already robust: clobazam, sodium valproate, and vigabatrin.
And there was a specific trigger mentioned, wasn't there?
Yes. About a month prior to this admission, she had an adenotonsillectomy. After that, her parents noticed a marked deterioration in seizure control. By the time she reached the neurosurgery unit, she was critically ill: cachectic, BMI of 12.2, tachycardic, and hypotensive at 75 over 40 millimeters of mercury.
The clinical description of the seizures was quite vivid in the report. They noted myoclonus, forced left gaze deviation, perioral cyanosis, and hypersalivation. When you have a patient who is already neurodevelopmentally delayed, the paper says she was at the level of a 5 to 6-month-old infant. Identifying the new neurological deficit in the middle of SRSE is incredibly difficult.
Definitely. Her EEG showed diffuse epileptiform activity. They ran the full battery. CT was clear of focal lesions. Viral and bacterial panels were negative for things like CMV, EBV, and Mycoplasma pneumoniae. They even used a 3 Tesla MRI with an epilepsy-specific protocol to try and localize the epileptogenic zone.
Now, this is where the neurosurgical intervention becomes the focal point. Typically, emergency epilepsy surgery is the last resort because of limited evidence, but these authors argue for a multi-modal approach. They didn't just do one procedure, they integrated 3 distinct techniques.
This is the most unique part of the report. It's one of the few cases worldwide where a patient received a sequential combination of a resective procedure, a neuromodulatory procedure, and a disconnection procedure. Specifically, a left selective amygdalohippocampectomy, or SAH, vagus nerve stimulation, VNS, and an anterior corpus callosotomy.
Let's break down that first step, the SAH. Why start there?
The SAH targeted the epileptogenic mesial temporal structures. The goal was to arrest the ongoing seizure activity by removing the primary generator while preserving the surrounding neocortex and neurovascular anatomy. The paper notes that this actually resulted in immediate seizure cessation upon completion of the surgery.
That's a powerful result in an emergency setting, but as often happens in these high-risk cases, the seizures weren't gone forever.
Correct. Following recurrent episodes after the initial SAH, the team moved to the next phases. They implanted a VNS for neuromodulation and performed an anterior corpus callosotomy to disconnect the pathways that allowed for seizure generalization.
For the residents listening, the rationale for the callosotomy here is key. In a patient with diffuse epileptiform activity and a history of generalized seizures, preventing that spread is often the only way to mitigate the systemic impact of the status, like the respiratory insufficiency and hypotension this girl was facing.
And the results were impressive. By combining these 3, resection, modulation, and disconnection, they achieved a sustained reduction in seizure frequency and severity. They categorized the outcome as Angle Class 2.
Angle Class 2 is a fantastic outcome for a patient who was essentially in a life-threatening tailspin. It means near-complete seizure remission. For someone with her comorbidities, that is a significant improvement in quality of life, and frankly, a life-saving intervention.
The authors make a strong case that we shouldn't wait so long. They mention that surgery is often only undertaken when pharmacological strategies have failed and the brain has already suffered irreversible damage. But this case suggests that early consideration of sequential surgical strategies can actually halt that exotoxic injury.
I think that's the main takeaway for our colleagues. SRSE is most frequently seen in patients with drug-resistant epilepsy. About 30% of DRE patients, especially those with generalized seizures, are at risk. If we know a patient is already in that 30% high-risk group, our multimodal evaluation for surgery should perhaps happen much earlier in the status epilepticus timeline.
Right, rather than waiting for the last resort stage. The paper notes that management of SRSE is currently unstandardized and highly individualized, often relying on high-dose sedatives, ketamine, or the ketogenic diet. But those don't address the structural or network-based drivers of the seizures the way surgery does.
It's also worth noting the technical surgical choice of a selective amygdalohippocampectomy. In an emergency, there might be a temptation to do a broader resection, but by being selective, they preserved as much functional tissue as possible in a child who was already dealing with quadriplegic cerebral palsy. It shows a high level of surgical planning even under the pressure of an emergency transfer.
And the VNS and callosotomy served as the safety net for the long term. It really highlights the need for a multimodal neurosurgical approach. You aren't just looking to stop the seizure today. You're looking to change the network's excitability for the future.
Any final thoughts from the case description, Alara?
Just the sheer complexity of the patient's recovery. Being cachectic with a BMI of 12.2 and having thoracolumbar neurogenic scoliosis makes any neurosurgery recovery difficult. The fact that she achieved Angle Class 2 despite these physical hurdles is a testament to the efficacy of the surgical combination.
It's a call to action for pediatric neurosurgeons to be part of the multimodal team early on in RSE cases, not just when the ICU has run out of options.
Absolutely. Well, that's all the time we have for today's deep dive. This case really underscores the potential of integrating resective, neuromodulatory, and disconnection procedures to save lives in the face of super-refractory status epilepticus. Thanks for joining us on the Neurosurgery Hub podcast. We'll link the full study in the show notes for those who want to review the EEG and MRI epilepsy protocols mentioned.
I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.